Then,
Yes.
yeah.
Hi. Good evening to all the viewers of FCPI. This is Akash from the FCPI Critical Care Forum, welcoming you all to the Critical Care Module 2. Uh, this module series is going to be the second part of FCPI's basic modules in critical care, which we have selected quite a few topics which we deal regularly as pharmacists in the ICU. So, one of the topics in this module 2 is hypernatremia, and the presenter for this topic is Abde Hussain. And I would like to introduce Abde by saying that Abde is now working as a clinical pharmacist in Medcare Hospital, Sharjah, where he has recently joined, and he has played a pivotal role for the JC accreditation of the hospital. Previously in India, Abde used to work as a critical care clinical pharmacist in KIMS Hospital, King's Kingsway Hospital, Nagpur, where he had implemented and pioneered an antimicrobial stewardship program and also had got hands-on experience in ECMO training. So I welcome you, Abde, for this presentation so that you can share this knowledge with all the viewers of FCPI. Over to you, Abde.
Thank you so much, Akash. Thank you for the kind introduction. And I welcome all the audience for this wonderful presentation today, a very informative one on a very crucial topic in ICU, hypernatremia. And we have seen a rise in trend of this situation occurring in a lot of ICU patients. So moving ahead, I have no disclosures. So our learning objectives here will be regarding how the hypernatremia occurs, what is the prevalence, what are different types of hypernatremia, the associated types that we see, the causes that can lead to hypernatremia, the diagnostic differentiation amongst them, and what will be our treatment goals, the choice of fluids, the rate of sodium correction, how fast should we correct it, and the role of desmopressin in the management of hypernatremia. So what is an essential hypernatremia here? So a sodium serum of more than 145 milliequivalent per liter and a raise in serum osmolality above 295 milliosmoles per kg. In ICU acquired hypernatremia, as per the sodium levels, we can distinguish them from mild to moderate to severe. For the most severe cases where you can see a sodium rise of more than 155 millimoles per liter. Now, this happens either due to two key reasons. Either there's a net rise in sodium levels in the blood, or there's a net loss of water compared to the sodium or the other electrolytes. So eventually there's an imbalance between the sodium and water that happens. So in ICU, either the prevalence can be a 2 to 6% of patients coming in admissions to ICU with hypernatremia due to various reasons, and approximately 6 to 26% of patients develop hypernatremia in ICU. This could vary depending on the type of ICU that you're dealing with. It could be more prevalent in cases where you have a neuro ICU, where there tend to be more patients for these cases. Now, what are different types of hypernatremia? So we can categorize this into three simple terms. So either it could be due to hypovolemia, or it could be a euvolemic hypernatremia or a hypovolemic hypernatremia. So in hypovolemia, as the name suggests, there's an excessive loss of water compared to the solute loss. So what are the two reasons? It could be either renal loss or a non-renal loss. The key reasons for renal loss could be an overzealous use of diuretics that we so often use, maybe in heart failure patients or in patients that are present in ICU with edema, which is very common. Then comes urinary obstruction, where once the obstruction is released released, so after that, the post-obstruction, there's an increase in diuresis, which can further lead to hypernatremia, although very uncommon. And then there's adrenal insufficiency, where there's a decreased amount of vasopressin, which essentially, holds the functioning of the kidneys, the handling of the solute and water by the kidneys. The other non-renal losses that we can observe are the GI losses, where severe diarrhea or vomiting that we see. Burn patients, there's a severe loss of water in that, and insensible losses that we so often hear people talking in ICU happening. Then the euvolemic hypernatremia. Either, a diluted urine is produced, although the, amount of water that is lost, it is not in that level to what we see in the causes for the hypovolemic causes. It could be subtle. It could not be too much water loss, but in cases like central DI, we can see a lot of you know urine getting produced. So different in the diluted urine, we can see diabetes insipidus, central DI, nephrogenic DI, a gestational DI. Very common changes. There are so many physiologic changes in the pregnant woman, so that can also lead to this disturbance and hypodipsia. Concentrated urine, where an inadequate water intake is there, a diminished thirst, maybe due to some drugs that could occur, or there could be some central changes that lead to this. And insensible losses again can lead to produce a concentrated urine. Whereas in hypovolemic hyponatremia, this could be either due to iatrogenic reasons, a lot of drugs or medications that contain high sodium content, like the sodium bicarbonate, saline infusion, then hyperaldosteronism and Cushing syndrome also associated with this. Now, in ICU, if we talk, what are the contributing factors that can lead further or can add that risk factor of developing patients with hypernatremia? In chronic liver disease, or the most common is hyponatremia, not hypernatremia. But in certain cases where there's, an imbalance between this renal handling of sodium and water, hyponatremia can occur in very few cases. Now, in diabetes, where there's a hyperosmolar condition because of the raised glucose, this can lead to more osmotic diuresis and further lead to more loss of water as compared to the sodium. In such of cases, we can see a lot of IV infusions going on. We do fluid resuscitations, and we at times tend to use solutions like normal saline, which can further add to the net sodium increase. High Apache scores in very vulnerable cases. So these patients tend to have an increased risk of developing hypernatremia in ICU. So again, patients requiring large amounts of fluid, apart from sepsis also, we have hemorrhagic shock and so many other conditions like pancreatitis also requiring large amounts of fluids. Then extrarenal losses. Now, these are the conditions that we also see in ICU developing, wherein insensible losses of more than 14 ml per kg per day, which can lead to hypernatremia, excessive loss because of fever, with a per degree rise of fever, there can be a further loss of 3.5 ml per kg per day of water. Diarrhea, sometimes, there are so many medications that are going on, or an infection that can lead to diarrhea, nasogastric suctions, any tubes or drains, high output tubes, also drains can lead to this. High doses of lactulose, so again, that more amount of osmotic elimination of water that can further lead to hypernatremia, especially when we use it in higher doses for cases like hepatic encephalopathy. Now we talk about the sodium content. So this gives a picture of how the drugs or the medications or the IV fluids that we are using, how much sodium content each of it has and how it can affect. So now thinking of fosfomycin, I think so most of you have heard this, that fosfomycin has a good amount of sodium in it. So if you consider a 4-gram TDS dose, that comes to around 12 gram per liter of fosfomycin sodium content. So that is again a huge amount. Then sodium metronidazole 0.32, piperacillin as well, ampicillin, sulbactam, and terpenem. So most of the drugs we commonly use in ICUs as well. So again, to look forward, like, we can minimize this, we can anticipate these medications which have higher sodium content. So ensure that, we can try for other fluid dilutions that are hyponatremic. The way sodium content in IV fluids, the most with NS 10%, although not available in India, but we can see NS 3% being used, and in some cases, very few places have NS 23% as well. So even with a higher sodium content. And sodium bicarbonate are most widely used buffer for acidosis in ICUs, and it can lead to a significant addition of sodium load in patients. Now, what are the consequences of hypernatremia? Why is it that bad, and why we need to have a control on it? So, hypernatremia essentially disturbs the physiology and can lead to hyperventilation, a more prolonged time of ventilator. A patient could be on ventilator for a longer time because, again, the things are not settled. A disturbed glucose utilization, so it effectively affects the insulin's mechanism to control the sugar levels. Again, there's an impaired gluconeogenesis. The symptoms that can be observed could be, in terms of cramps or rhabdomyolysis as well. So that's severe it can go to. Now, talking about the hypernatremia and its effect on the brain. So now, what hypernatremia leads to? It sucks the water from the intracellular fluids. So all the material or the water that is in the intracellular level, it comes out into the extracellular space, and there's essential cell shrinkage. Now, this can lead to various drastic effects on the brain. It can lead to brain damage, cellular damage, demyelination. So all these effects can develop with more severe cases and for a prolonged time if hypernatremia is present. Now, decreased left ventricular contractility again can happen because of the increased sodium and the increased load on the heart. So eventually, if the sodium levels are high or persistently high, brain can adapt to a certain extent, beyond which, it cannot. So in acute cases, we can correct the sodium fast, but in chronic cases, we have to be careful because the brain is adapted to that level of sodium levels. Now, what are the primary causes of hypernatremia that we usually see? So a polyuria that we can observe where the urine output is of more than 50 ml per kg per day, and with a urine osmolality of less than 300 milliosmoles. The causes could be either polydipsia, psychiatric illnesses, sarcoidosis, any trauma patients also, phenothiazine use, impaired ADH release, which could be due to central DI, and resistance to the action of ADH, also called as nephrogenic DI. So furthermore, in the central DI, what we see, the most common causes of central DI are post-traumatic, post-surgical, brain injury patients, all those surgeries, brain surgeries that are very close to the pituitary gland or the hypothalamus. Those are the main areas of concern where the more chance of central DI being developed. In metastatic tumors that are close to the pituitary, CNS infections, post-cardiac arrest, and congenital DI. Now, the urine osmolality that we observed is less than 300 milliosmoles per kg, and an overnight water deprivation test with desmopressin can help us identify the central DI. Also, copeptin levels can be checked, which is a precursor or a navigator towards how the vasopressin content is present. Now, to just explain on how this plays out, so pituitary eventually releases AVP, the arginine vasopressin, which stimulates the kidney to reabsorb the water and not produce a diluted urine. A proper balance of urine is produced. Since in central DI, this pathway is damaged, which can lead to a decrease in release of arginine vasopressin. So control on kidney is lost. And this leads to an increased production of free water, and the water absorption is decreased. So basically, a diluted urine is produced over here. Whereas in nephrogenic DI, we observe that even though the vasopressin is being released, but the kidney cells or the aquaporins receptors that help regulate the functions of AVP, those are resistant to it, and so we do not observe any effects of AVP, although it is present in normal levels over here. So in nephrogenic DI, just to bring out that urine osmolality here is again less than 300 milliosmoles per kg. The causes that can cause nephrogenic DI are CKD, hypokalemia, hypercalcemia, a protein malnutrition, sickle cell disease, use of lithium, which can impair or affect the function of the equiporints, or a demeclocycline treatment, and recently even sevoflurane use has been uh, one of the causes for nephrogenic DI has come up. Now, how to differentiate these, although not used in ICU, the water deprivation test, but still just a key factor to note here how we can test whether what was the reason of hypernatremia in certain cases. So the patient is not given water overnight for 8 hours. So what this will lead to a reduction in water in in the blood, and eventually there should be a rise in the osmolality because comparatively now the sodium is more as compared to the water. Now this should stimulate a release of arginine and vasopressin from the pituitary gland, and it should act on the kidneys. So due to this, the expected production of a concentrated urine should be there, and the subsequent rise in the urine osmolality of more than 700 milliosmoles. Now, after we have done this, then we check if if there is a rise or not. If suppose there is a rise, then there's no issue in the functioning over here. But if we do not observe a rise in the urine osmolality, then we go ahead with the desmopressin injection. Once it is given, the expected net result is there should be a rise in the urine osmolality again after the administration of desmopressin. And if so, if it is not observed, then this either points to a nephrogenic DI. So that means the desmopressin even cannot work on the receptors. So there's some resistance towards it. Now, coming to the part of management of hypernatremia. So our treatment goals will be to correct the reversible factors, the correcting volume depletion that has occurred if it is a hypovolemic hypernatremia, replacing the calculated free water deficit. We have heard about the insensible losses, the GI losses, and all those things in this. The free water loss that has occurred as compared to the sodium, we correct that, and administration of hypertonic solutions. So just to get a workflow of how we can manage different types of hypernatremia, if it is a hypovolemic or a euvolemic, whether ADH is present or not, whether it is a hypovolemic. So first, just a key short one on hypovolemia, hypovolemic hypernatremia, where we have given a lot of fluids, a lot of hypertonic solutions. So we restrict that first and also treat the hyperaldosteronism or Cushing syndrome that will eventually, correct the hypernatremia. For hypovolemic or euvolemic, the things are a little different. We observe whether the urine osmolality, how much it is, whether ADH is present or not, whether it is effectively working or not effectively working. So in the first case, we see there is a decreased water intake. So we try to replenish that lost water or the decreased water intake in these patients. The second will be to osmotic diuresis, adding a little bit of diuretics so that with the fluid intake, there is an additional loss of solutes. So that effectively those stopping the diuretics and only the solutes are eliminated. In central DI, we use desmopressin, and in nephrogenic DI, we have to address the underlying cause. If the hypernatremia onset is acute, the current recommendation or the rapid correction should be undertaken of at least 2 to 3 mmol per liter per hour. Max that we can go is 12 mmol per liter per day. Whereas in a chronic, we have to be a more conservative and a slow correction is advisable. Volume status should be checked, whether it's hypovolemic, where an initial resuscitation can be done with a point normal saline, and then eventually we can switch to a dextrose 5% or have isotonic solutions. In euvolemic, we target both the volume as well as the solute excretion. And same goes for hypervolemia, where we restrict the solute intake, but and also replace the volume loss. Now, fluid correction, how to go about the fluid correction, hypovolemic patients. So hypovolemic patients are having they are in hemodynamic compromise. So first we need to address that. Their blood pressures would be hitting low, and this we have to resuscitate them with sufficient amount of volume. So initial correction should be done with isotonic saline, and the volume deficit and hemodynamic stability once achieved, we can switch to a hypertonic solution. So now this we calculate also the free water deficit that has occurred. So the formula that helps us estimate how much of free water deficit has occurred. The correction of the deficit with hypertonic solution can be undertaken by the half deficit corrected in the first 24 hours, and the subsequent deficit correction occurs in the next 24 to 48 hours. Rapid correction of sodium also can lead to raised ICP. So this is one of the major concerns where we have to think about how fast we can go in the fluid correction. So here we have one fluid correction case to understand how we can go about the fluid correction here. So 70-year-old male with vomiting and diarrhea with a weight of 70 kgs. The serum sodium levels are 160 MEq per liter, again a severe one. Then appears to be fatigued with cool, clammy skin with ongoing losses of diarrhea of 2 liters, a urine output of 1 liter over 24 hours. So case of hypovolemic hypernatremia here, and patient appears to be in shock. So we should resuscitate this patient adequately first with a point normal saline, at least 1 to 2 liters. We calculate the free water deficit with the formula. So 0.6 into 70, 42. Then for the calculation, so approximately the free water deficit comes to around 42 liters. Sorry, 5.9 liters, sorry, I say. So the target lower sodium by max we should be doing is 10 to 12 MEq per liter in 24 hours. So if we see the approximate free water deficit that we calculated here, it comes around 6 liters. So in the first 24 hours, we can replace 3 liters of fluid. And in the remaining next 24, 48 hours, we can do it with half normal saline, the next 3 liters. And we should monitor sodium levels severely every 4 to 6 hours, checking on how good we are doing with the correction. Now, going with the fluid correction with the Edrog-Medias equation, the change in sodium per liter, this is a formula, and how much expected change of sodium per liter with the infusate we can see. So applying the formula, we can see with the if we use 5% dextrose as a solution here, so calculating through this formula, we can find out exactly the rate of infusion of 1 liter of fluid that needs to be given to a patient. So in this case, if we take the case, 1 liter fluid should be replaced over 7 to 8 hours as per the formula. So the rate of infusion then will come over 8 hours will be 125 ml per hour. Plus, we also need to account for the ongoing water losses per day. So 3 liters per day divided by 24, again 125 ml per hour. So the total fluid rate correction that we can give is up to 250 ml per hour. And these are the various infusate sodium for selected fluids that we can expect changes after administration of 1 liter of these solutions. Now, a little about fluid correction rate. There's one study on how fast we should go, whether it's advisable and its effect on mortality. Whereas in overall hypernatremia patients that got admitted, it favored a faster correction as well, only for acute hypernatremia. Then admissions, hypernatremia that come in again favored fast, but if it is hospital acquired, it could not favor both. So it is, a bit of tricky thing here, whether, fast or slow, which correction is correct. One more, one study again notified that, a 7-day mortality effect was not there, although a 30-day mortality and 1-year mortality was better with a faster fluid corrections. Now, treatment of normovolemic hypernatremia, central DI, where the urine output of greater than 300 ml per hour for at least 2 hours, hypertonic urine, essential to distinguish from solute diuresis is required, and a plasma hyperosmolarity. In these cases, once we have identified that it is central DI, we can use desmopressin, either intravenous or subcutaneous initially. If you don't have an IV line or something, we can use intranasal application of desmopressin as well. And if it's a chronic, we can use oral desmopressin as well. For nephrogenic DI, so the various causes we can account for can be managed accordingly, where CKD will essentially manage the daily intake and output. We rectify the hypercalcemia or hypokalemia that is happening. For lithium toxicity levels, we can adjust the doses of lithium. Mostly it occurs due to lithium toxicity. And even if due to lithium normal conditions are happening, we can use amiloride. For demiclocycline abuse, we should discontinue the drug. So just a sample case here, a 65-year-old patient with a history of bitemporal hemianopsia is undergoing a surgical evaluation. The MRI reveals a craniopharyngioma, so a tumor very close to the pituitary and hypothalamus, and the surgeon chose a transsphenoidal hypophosphatemectomy to treat. 2 hours after the surgery, he develops a polyuria, a 375 ml per hour, which is quite high, and a hypernatremia is ensuing with a 155 ml per liter. The patient describes severe thirst, seems lethargic and disoriented. So, which is of the following the next best step in the management of this patient? So, is vasopressin indicated? Is amiloride the right choice? Should we start desmopressin or hydrochlorothiazide? So for this, we need to understand what kind of hypernatremia cause this is. So clearly, this is a post-op patient and a surgery that involved manipulation near an area of pituitary and hypothalamus. So high suspicion of central DI. And with high polyuria and hypernatremia, this seems to be a case of central DI. So the choice would be intravenous desmopressin for this patient for the management of hypernatremia. So the key takeaways. Another thing that I would like to mention here in ICU patients, like why they develop or why they are at risk of developing hyponatremia. Now, two things could be there. Either we are giving too much of fluids, or which add to the total net sodium content, or it is the opposite, where we are depriving the free water, like in cases where a patient is on ventilator, or there are so many other conditions where the patient cannot tell that they are thirsty. So they won't be able to tell that, they need water and they are feeling thirst, because that's a natural response when you become hypernatremic, when the osmolality goes up. So that is one of the key uh, reasons that could occur, and we could miss out on this and can lead to hypernatremia in ICU patients. And plus, ICU patients with neurological complications are at risk of developing hyponatremia for the reasons that we have just seen. Even in trauma patients also, where there's a brain injury involved. Then hyponatremia again can contribute to the increased mortality in ICU. Hence, it is very essential to monitor this to correct it adequately. Ventilator time can go up, and all those things can again increase in the length of stay in ICU as well. And with the increased length of stay, other things can creep up. Then hypernatremia can be either hypovolemic, euvolemic, hypervolemic. We have to distinguish between them and initiate the appropriate management accordingly. And we should always avoid the inappropriate treatment, which can be more deleterious than the condition itself. Further references that one can go through for further reading. And thank you.
Thank you, Abdi, for that wonderful and informative session on hypernatremia. Uh, so just about hypernatremia, like sodium disorders are very common in ICU settings. whether it be hypo or hypernatremia. What do you think the pharmacist should focus on?
Yes, absolutely. So, one thing would be to notice any drug-induced hypernatremia is occurring. So, overzealous use of diuresis. So, a diuretic stewardship can come into effect over here, where a clinical pharmacist can, adjust the doses of diuretics over here. Lithium, I know it's very less commonly used, so one of the drugs. Then one can in ICU participate in the calculation of fluid amounts here, how much fluid we can choose. Even I at times have used this methodology where if I see hypernatremia, I would check which all fluids that are ongoing to the patient and what kind of fluid they are using for diluting the medications. Uh, we will be using so much, 3 to 4 liters extra amounts of normal saline that is going to the patient along with these antibiotics, other drugs as well. So in these cases, just identifying what are the compatibilities, what are the stabilities of these solutions in hypertonic solution, although the data at times is not that much available, but still trying to see if there's any possibility where we can use a hypertonic solution for diluting these medications and what will be the stability. So again, the drug effect is not lost and help in the cases in such cases.
Yeah, absolutely. What I've also observed the same thing. One thing is diuretics. Whenever a diuretics goes, I think pharmacists can actually prompt that every 48 hours, a urea and a sodium potassium can be checked in ICU. That is very that I found it very useful in ICU setting. Another thing is that steroids. The patient is on a steroid. Definitely, patients do have a tendency of hyperaldosteronism, which leads to hypernatremia again fluid, what type of fluid is going? Are we using a fluid which is containing a lot of sodium and chloride or not? And especially in treatment where large volume fluid resuscitation is needed, like trauma, sepsis, burns, decay. So in these cases, if you give a lot of sodium containing fluids, again, so 30 times the deficit is also not recovered, but at the same time, your sodium also gets trending up. Uh, always observed. So, and another the same thing, diluting your medications wherever possible. The pharmacist can always tell the nurses, the doctors, yes, we can dilute these drugs in dextrose or in harfinase so that actually it comes down. The sodium load is a bit less on the patients. So these are very good practice points, Abde. So I hope this would have been a good informative webinar. We'll be viewing this shortly on the FCPI website. And stay tuned from the FCPI website so that we can bring to you more such webinars, more such topics. So, signing off from the FCPI end. Thank you.
Thank you, Akash. Thank you.